This program is brought to you by Hometown Veterinary Partners. Learn how you can get on the pathway to partnership at hometownvetpartners.com/vetcandy.
Hey y'all, it's Dr. Deja. As a vet at Hometown Veterinary Partners, I'm excited to work with Vet Candy on this project. NAVLE prep can be really stressful, and we're here to help. Tonight, we have an engaging topic and a top-notch expert to share their knowledge. To learn more about Hometown Veterinary Partners and how you can get on the Path to Partner program, check out hometownvetpartners.com/vetcandy. Okay, let's get started.
Hi everyone, I'm Dr. Sid Sudunagunta, a board-certified veterinary cardiologist working in the UK. I'm pleased to work with you tonight on Vet Candy's NAVLE prep. Let me tell you a little bit about myself. I graduated from the Royal Veterinary College in 2011. I did complete the NAVLE exam along the way, although I never ended up working in the US. I completed my cardiology residency at the University of Liverpool in 2020 and passed my European board exams the following year. I'm currently working at a multidisciplinary hospital in the Midlands. I'm looking forward to discussing some cardiac topics with you. I hope you find them useful for the exam, but also for your career going forward. If you have any questions for me, just post them in the chat and we will answer them for you. Okay, let's get started. First up, let's talk about congenital heart abnormalities. Congenital cardiovascular abnormalities are birth defects generally resulting from genetic predispositions and environmental influences. In people, infections, toxins, medications taken by the mother, or inadequate maternal nutrition can contribute. I don't know how well established this is in small animals. Some defects have suspected hereditary origins, particularly evident throughout breed tendencies and breeding studies. However, congenital heart disease is relatively rare in dogs, affecting less than 1% of the canine population. In addition to congenital heart issues, several other cardiovascular disorders are thought to have genetic origins. Conditions such as hypertrophic cardiomyopathy, dilated cardiomyopathy, and degenerative valve disease may exhibit a significant genetic component, especially in certain breeds. Among dogs with congenital heart disease, the most common defects are patent ductus arteriosus, or PDA, pulmonic stenosis, aortic stenosis, persistent right aortic arch, and ventricular septal defect. Less frequent defects, occurring in fewer than 5% of cases, include Tetralogy of Fallot, atrial septal defect, mitral valve dysplasia, tricuspid valve dysplasia, and cor triatriatum dexter or sinister. The prevalence of these defects varies regionally, with differences observed between countries. Early detection of congenital heart defects is crucial for effective intervention and treatment. Some defects are surgically correctable, but treatment is most effective before the onset of congestive heart failure or irreversible damage. Early detection also allows for informed breeding decisions to prevent the propagation of genetic defects. A thorough physical exam is critical for the diagnosis of congenital defects. It's one of the areas that makes for good exam questions because you can infer a huge amount from the signalment and nature of the murmur, so it's a good idea to have this in your mind. We will go into these in more detail, but if you have, say, a French Bulldog puppy with a left basal murmur, pulmonic stenosis should be top of your list. A young Labrador with a right-sided murmur, well, they're predisposed to tricuspid valve dysplasia. It's that sort of thing. The diagnostic tests are typical of cardiac disease. With any murmur investigation, echocardiography is the diagnostic tool of choice for identifying the cause of the murmur and the associated defect. Radiographs are often helpful as well, but sometimes will not give you a specific diagnosis. Rather, they will tell you about the presence of cardiomegaly, for example. Arrhythmias aren't very common in congenital defects, and as such, ECGs, or EKGs as you call them in the US, aren't often a mandatory part of investigations. The clinical significance of congenital heart disease depends on the specific defect and its severity. Mildly affected animals may show no symptoms and lead normal lives, while severe defects can lead to neonatal death or severe circulatory disturbances. Treatment options range from medical management to surgical intervention, depending on the condition and its severity. It is important to note that not all heart murmurs in young animals indicate congenital heart defects. Innocent murmurs, caused by benign turbulence of blood flow, are common and typically resolve by 6 months of age. However, high-grade systolic murmurs, or the much rarer diastolic murmurs, warrant further investigation for underlying cardiac disease. Now let's go into more detail about specific congenital heart abnormalities in dogs. First, patent ductus arteriosus, or PDA. In a normal fetus, the ductus arteriosus allows blood to bypass the non-functioning lungs, but should close shortly after birth. If it remains open or patent, it leads to abnormal blood flow between the aorta and the pulmonary artery. In terms of the clinical signs, PDAs are often diagnosed incidentally. However, if untreated, patients can develop volume loading and left-sided congestive heart failure with tachypnea, dyspnea, exercise intolerance, and lethargy. A continuous heart murmur, sometimes described as a machinery murmur, is the typical cardinal clinical sign. It is almost pathognomonic, though you can have other arteriovenous communications that theoretically can cause a continuous murmur, such as an aortopulmonary window. These are much, much rarer, however, and a continuous murmur should immediately make you think PDA. These patients may have hyperdynamic femoral pulses. In the older textbooks, they were described as water hammer pulses. So when you're diagnosing a PDA, again, physical examination is key. The murmur is extremely suggestive. Echocardiography allows visualization of the defect. Thoracic radiographs may show a typical triple knuckle with bumps corresponding to the aortic arch, main pulmonary artery, and left auricle. This appearance is typical of PDA. Ideal treatment is closure of the PDA to prevent complications like left-sided congestive heart failure. Closure can be performed in a minimally invasive manner or via thoracotomy and ligation. Successful closure should be completely curative. I'll briefly touch on reverse PDAs. This is when the large flow causes the shunt to reverse, i.e. travel right to left. This is pretty terrible, as the PDA can no longer be closed. Interestingly, patients with a right to left shunting PDA don't typically have heart murmurs. The typical historical and clinical findings include exercise intolerance with pelvic limb weakness and what they call differential cyanosis, which is to say, cyanosis of the caudal mucous membranes in, say, the genitals, while the cranial mucous membranes, like the gums, are normal. The reason for this is the shunt in the aorta occurs after the brachycephalic trunk and left subclavian artery branch off from the aorta and towards the head, so the shunted, deoxygenated blood only travels caudally. Pulmonic stenosis is a narrowing of the pulmonary valve or artery, obstructing blood flow from the right ventricle to the lungs. There are really certain breed predispositions to this, typically brachycephalic breeds. Among these, French Bulldogs have really become the poster breed for this condition, certainly here in the UK. Other breeds, such as English Bulldogs and Boxers, are prone, as are Beagles and Cocker Spaniels. In pulmonic stenosis, a left-sided basal systolic murmur is the typical clinical sign. This is also true of aortic stenosis, and these are the two typical congenital defects that have this type of murmur. Moderately or severely affected animals can develop weakness, exercise intolerance, or collapse and signs of right-sided congestive heart failure. These patients can develop arrhythmias, and sudden cardiac death is possible, although uncommon. When it comes to diagnosing pulmonic stenosis, again, physical examination is really important. The murmur is extremely suggestive, and if you have a brachycephalic breed, I would think pulmonic stenosis first, though do be aware that boxers get aortic stenosis very commonly as well. Echocardiography allows visualization of the defect and assessment of severity, which informs treatment options. Thoracic radiographs may show right-sided cardiomegaly and an enlarged pulmonary artery. The treatment of pulmonic stenosis depends on its severity. Mildly affected animals may need no treatment or simply medical management with beta blockers, such as atenolol. In more severe cases, balloon valvuloplasty or stent implantation is the treatment of choice. There are some centers who perform open heart surgery as well. Next, aortic stenosis. Aortic stenosis refers to narrowing of the aortic valve, or the region below it, obstructing blood flow from the left ventricle to the body. In contrast to pulmonic stenosis, which typically has a valvular component, subaortic stenosis is common in dogs, with a muscular ridge beneath the valve being the cause of the obstruction, rather than necessarily being valve pathology. At-risk breeds include boxers, golden retrievers, German shepherds, and English bull terriers. As I touched on earlier with pulmonic stenosis, in aortic stenosis, a left-sided basal systolic murmur is the typical clinical sign. This makes a lot of sense when you consider the anatomy of the heart and the great vessels. The aortic and pulmonic valves are really next to each other on top of the heart base. Moderately or severely affected animals can develop weakness, exercise intolerance, or collapse, and signs of left-sided congestive heart failure. These patients can sometimes develop arrhythmias, and again, sudden cardiac death is possible, although uncommon. So let's talk diagnosis. And again, and I know I'm repeating myself, physical examination is really important. That left-sided basal systolic murmur should alert suspicion. Patients with severe aortic stenosis often have weak femoral pulses as well. Echocardiography is important for diagnosis and assessing severity. When it comes to the treatment of aortic stenosis, medication, for example beta blockers, are most commonly pursued. Cutting balloon valvuloplasty is reported for severely affected patients in whom medication isn't controlling clinical signs, though most patients are not amenable to this. Next, we'll talk about ventricular septal defects, or VSDs. A VSD is an abnormal opening between the left and right ventricles, leading to abnormal blood flow within the heart. This is probably the most common congenital defect in cats. The symptoms of VSDs vary depending on the size and severity of the defect, ranging from none to severe congestive heart failure. A lot of VSDs are small and not hemodynamically significant. These are referred to as being restrictive. Apologies if you can hear my kittens making a noise in the background. Let's talk diagnosis. Patients with a VSD often have a right-sided murmur. This makes sense when you consider that the blood is flowing from left to right across the defect. Interestingly, patients with louder murmurs may not have severe defects, in contrast to a lot of other cardiac diseases. The reason for this is because in VSDs, a louder murmur may be associated with a smaller defect, which is therefore more likely to be non-hemodynamically significant. Echocardiography, often using color Doppler, is the best way to diagnose a VSD. Radiographs may be normal unless there is dramatic cardiac remodeling, and even in this case, it wouldn't be specific to a ventricular septal defect. The treatment for VSDs is either medical management of the congestive heart failure or other clinical signs, or surgical closure, depending on the size and specific nature of the defect. Next is Tetralogy of Fallot. Tetralogy of Fallot is a complex congenital heart defect. Tetralogy refers to the presence of 4 cardiac changes, specifically pulmonic stenosis, a ventricular septal defect, an overriding or dextroposed aorta, and right ventricular hypertrophy. Tetralogy of Fallot can affect any breed, but specific breeds at risk include Keeshonds and English bulldogs. The clinical signs of Tetralogy of Fallot: typically you have a left basal murmur caused by the pulmonic stenosis, and that is the easiest to identify, although the heart murmur can radiate widely. These patients are often cyanotic because the VSD tends to shunt from right to left. This can cause exercise intolerance, collapse, and even seizures due to the hypoxia and/or polycythemia. Diagnosis is usually made via echocardiography to identify those cardiac changes I mentioned. Radiographs will show right heart enlargement and often undersized pulmonary vessels. In terms of treatment, medical management with beta blockers and periodic phlebotomy to control polycythemia. Surgical interventions may be considered in select cases. The prognosis of Tetralogy of Fallot is guarded, and the outcomes are influenced by the severity of the defects and the response to treatment. Okay, let's go through some cases. First up, we have a 4-month-old female Cavalier King Charles Spaniel who presents for a wellness exam. During the physical examination, a continuous, machinery-like murmur is auscultated at the left heart base. The puppy is otherwise asymptomatic, with normal activity levels and no apparent exercise intolerance. So, what is the most likely diagnosis? Is it A, pulmonic stenosis, B, aortic stenosis, C, a patent ductus arteriosus, D, a ventricular septal defect, or E, mitral valve dysplasia? What are your thoughts on the correct answer and why? Let me know in the chat. Did you get it? The correct answer was C, patent ductus arteriosus. A continuous, machinery-like murmur is highly characteristic of PDA, especially in a young dog. This condition is due to failure of the ductus arteriosus to close after birth, leading to abnormal blood flow between the aorta and pulmonary artery, which occurs throughout the cardiac cycle, so not just during systole or diastole. Option A, pulmonic stenosis, was incorrect. Pulmonic stenosis typically presents with a systolic murmur, not a continuous one, and it's located at the left heart base. Option B, aortic stenosis, was also incorrect. Aortic stenosis generally presents with a systolic ejection murmur heard best at the left heart base, not a continuous murmur. Option D, ventricular septal defect, was incorrect. A VSD usually presents with a harsh systolic murmur, best heard on the right side, not a continuous murmur. And option E, mitral valve dysplasia, was incorrect. Mitral valve dysplasia typically presents with a systolic murmur heard best at the left apex and not a continuous murmur. Okay, are you ready for another case? This next patient is a 2-year-old male English bulldog who presents with a history of exercise intolerance and occasional fainting episodes. On physical examination, a harsh systolic murmur is auscultated at the left base. Thoracic radiographs reveal right ventricular enlargement. So, what is the most likely diagnosis? Is it A, aortic stenosis, B, pulmonic stenosis, C, a patent ductus arteriosus, D, Tetralogy of Fallot, or E, a ventricular septal defect? What are your thoughts on the correct answer and why? Let me know in the chat. The correct answer was B, pulmonic stenosis. A harsh systolic murmur at the left heart base, combined with right ventricular enlargement on radiographs, is indicative of pulmonic stenosis, particularly in a breed predisposed to this condition, like the English Bulldog. Option A, aortic stenosis, was incorrect. Aortic stenosis typically presents with a systolic ejection murmur and left ventricular enlargement, not right ventricular enlargement. Option C, patent ductus arteriosus, was incorrect. Remember, PDA presents with a continuous murmur, not a harsh systolic murmur, and generally causes left-sided enlargement. Option D, Tetralogy of Fallot, was incorrect. Tetralogy of Fallot involves multiple defects, including a VSD and right ventricular hypertrophy, and typically presents with cyanosis and a combination of murmurs. Option E, ventricular septal defect, was incorrect. VSD typically presents with a systolic murmur heard best on the right side and doesn't specifically cause right ventricular enlargement alone. Okay, are you ready for another case? Now we have a 5-year-old male golden retriever who presents with a history of exercise intolerance and occasional fainting episodes. On physical exam, a loud systolic ejection murmur is auscultated at the left heart base, radiating to the carotids. The femoral pulses are weak and delayed. So, what's the most likely diagnosis? Is it A, pulmonic stenosis, B, aortic stenosis, C, patent ductus arteriosus, D, mitral valve dysplasia, or E, Tetralogy of Fallot? What are your thoughts on the correct answer and why? Let me know in the chat. Did you get it? The correct answer was B, aortic stenosis. A loud systolic ejection murmur at the left heart base, radiating to the carotids, combined with weak and delayed femoral pulses, is characteristic of aortic stenosis, especially in a breed predisposed to this condition, like golden retrievers. Option A, pulmonic stenosis, was incorrect. Pulmonic stenosis presents with a systolic murmur at the left heart base, but it does not radiate to the carotids or cause weak femoral pulses. Option C, patent ductus arteriosus, was incorrect. PDAs present with a continuous murmur and generally cause left-sided heart enlargement, but no weak femoral pulses. Option D, mitral valve dysplasia, was incorrect. Mitral valve dysplasia typically presents with a systolic murmur heard best at the left apex, not at the left heart base with radiation to the carotids. And option E, Tetralogy of Fallot, was incorrect. Tetralogy of Fallot presents with a combination of murmurs and cyanosis, not just a loud systolic ejection murmur. Are you ready for another case? This time we have a 1-year-old female cat who presents for a wellness check. During the exam, a loud systolic murmur, grade 4 out of 6, is heard best over the right sternal border. The cat is asymptomatic and shows normal activity levels. So, what is the most likely diagnosis? Is it A, a patent ductus arteriosus, B, pulmonic stenosis, C, aortic stenosis, D, a ventricular septal defect, or E, mitral valve dysplasia? What are your thoughts on the correct answer and why? Let me know in the chat. Did you get it? The correct answer was D, ventricular septal defect. A loud systolic murmur heard best over the right sternal border is indicative of a VSD, particularly in a young asymptomatic cat. Option A, patent ductus arteriosus, is incorrect. PDAs present with a left-sided murmur, not right-sided. In dogs, the PDA murmur is continuous. However, interestingly, in cats, they can be systolic. Option B, pulmonic stenosis, was incorrect. Pulmonic stenosis typically presents with a systolic murmur at the left heart base, not the right sternal border. Option C, aortic stenosis, was incorrect. Aortic stenosis presents with a systolic ejection murmur at the left heart base, radiating to the carotids, not the right sternal border. And option E, mitral valve dysplasia, was incorrect. Mitral valve dysplasia presents with a systolic murmur heard best at the left apex, not the right sternal border. Okay, we'll do one more case on congenital defects. A 3-year-old male keyshound presents with a history of exercise intolerance, cyanosis, and occasional collapse. On physical exam, a left basal systolic murmur is detected. Radiographs show signs of right ventricular hypertrophy. Echocardiography reveals structural abnormalities consistent with pulmonic stenosis, a ventricular septal defect, right ventricular hypertrophy, and an overriding aorta. So, what is the most likely diagnosis? Is it A, pulmonic stenosis, B, aortic stenosis, C, patent ductus arteriosus, D, tetralogy of Fallot, or E, ventricular septal defect? What are your thoughts on the correct answer and why? Let me know in the chat. Did you get it? The correct answer was D, tetralogy of Fallot. The combination of exercise intolerance, cyanosis, left basal murmur, right ventricular hypertrophy, and the echocardiographic findings of pulmonic stenosis, ventricular septal defect, right ventricular hypertrophy, and an overriding aorta is diagnostic of tetralogy of Fallot. Answer A, pulmonic stenosis, was incorrect. While pulmonic stenosis is part of tetralogy of Fallot, it alone does not account for the full range of symptoms and structural abnormalities. Option B, aortic stenosis, was incorrect. Aortic stenosis does not typically cause cyanosis, and it does not present with the multiple structural abnormalities seen in tetralogy of Fallot. Option C, patent ductus arteriosus, was incorrect. PDA presents with a continuous murmur and typically does not cause right ventricular hypertrophy or cyanosis. And option E, ventricular septal defect, was incorrect. While VSD is part of tetralogy of Fallot, it alone does not explain the full range of symptoms and structural abnormalities. Next up, let's talk about congestive heart failure. Congestive heart failure is a complex syndrome characterized by the heart's inability to maintain sufficient output to the body's needs or to do so at normal filling pressures. While it's challenging to precisely define heart failure, veterinarians recognize it through a set of clinical signs indicative of impaired cardiac function and reduced cardiac output. The consequence of this is increased volume and pressure within the left or right atrium. The chamber can dilate to a certain degree to accommodate this, but when the pressure exceeds a certain threshold, it's transferred to the veins, either the pulmonary veins or the vena cava. Increased pressure within these vessels will ultimately result in fluid being extravasated, either into the lungs, which is pulmonary edema, the pleural space, which is pleural effusion, much more common in cats, or in the abdomen, called ascites, in right-sided heart failure. Congestive heart failure in dogs manifests through various clinical signs depending on whether it's left-sided or right-sided. So, left-sided heart failure often leads to pulmonary edema, typically presenting as tachypnea and/or dyspnea. Coughing is controversial. Historically, it's been termed a sign of congestive heart failure, but nowadays it is thought to be more likely related to concurrent respiratory disease, which can be exacerbated by cardiac changes. Pulmonary crackles may be heard on cardiac auscultation. However, this is not very sensitive or specific. Many dogs with congestive heart failure will not have crackles, and other disease processes, particularly pulmonary fibrosis, can cause crackles. On the other hand, right-sided congestive heart failure results in hepatomegaly and ascites due to increased venous pressures within the abdomen. The diagnosis of congestive heart failure involves a combination of clinical evaluation, including history taking and physical examination, along with diagnostic tests such as thoracic radiographs and echocardiography. Radiographic findings of left heart failure typically include cardiomegaly with left atrial enlargement, pulmonary venous congestion, and pulmonary edema. Echocardiography helps assess cardiac structure and function, but does not confirm the presence of congestive heart failure in most cases. That said, with skill and experience, you can use echo to infer the likelihood of congestion. With right-sided heart failure, ascites can be suspected based on physical examination and the presence of a fluid thrill, though milder volumes may not be palpable. A positive hepatojugular reflux test is also suggestive of right-sided heart failure. Abdominal ultrasound can identify ascites, as well as hepatomegaly and enlarged hepatic vessels. We can consider the management of congestive heart failure to be separated into acute treatment and chronic treatment. The acute phase of congestive heart failure management focuses on stabilizing the patient and relieving congestion. Oxygen supplementation is crucial to improve tissue oxygenation, especially in dyspneic patients. Loop diuretics, such as furosemide, are administered to reduce fluid overload, often in conjunction with oxygen therapy. Diuretics are the most important component of congestive heart failure management. All other medications are, to some extent, optional. Pimabendin is a drug with two effects: calcium sensitization, which promotes calcium binding to troponin C within the cardiomyocytes, improving contractility, and phosphodiesterase 3 inhibition, which causes vasodilation and improves perfusion. This is termed inodilation. Pimabendin is important in both the acute and chronic management of heart failure, though there are certain conditions in which it's contraindicated. Most importantly, if there's obstruction to outflow, such as in aortic or pulmonic stenosis, it can be dangerous to administer pimabendin and increase the cardiac contractility behind the obstruction. Chronic management of congestive heart failure aims to control clinical signs, prevent decompensation, and improve the patient's quality of life. A standard regimen includes medications like furosemide, pimabendin, angiotensin-converting enzyme inhibitors, or ACE inhibitors, and spironolactone. Furosemide helps manage fluid retention, while pimabendin improves cardiac contractility. You may remember that the renin-angiotensin-aldosterone system, or RAS, is activated in heart disease and heart failure, and this is further promoted by diuretics. However, RAS activation is deleterious over a long time. ACE inhibitors and spironolactone work to oppose the RAS. ACE inhibitors work by blocking the action of an enzyme called ACE, which is involved in the production of angiotensin II. Angiotensin II is a hormone that causes blood vessels to constrict and stimulates the release of aldosterone, another hormone that causes sodium and water retention in the body. By inhibiting ACE and reducing the production of angiotensin II, ACE inhibitors help to dilate blood vessels, lower blood pressure, and decrease the workload on the heart. Additionally, they reduce the release of aldosterone, leading to less sodium and water retention, which helps to decrease fluid overload in conditions like congestive heart failure. Spironolactone is an aldosterone antagonist, which reduces its activity. Overall, by reducing the effect of these neurohormones, ACE inhibitors help to improve cardiac function and alleviate symptoms associated with heart failure. Close monitoring of patients with congestive heart failure is essential to assess treatment response and detect any complications. Regular follow-up visits, thoracic radiographs, and laboratory tests are part of the monitoring protocol. Prognosis varies depending on factors like underlying cardiac disease and response to treatment. While a good quality of life should be achievable with appropriate medication, the prognosis for congestive heart failure should be considered to be guarded, and it is essentially not curable, with the exception of valve repair surgery for patients with myxomatous mitral valve disease. So in conclusion, congestive heart failure in dogs presents a significant challenge for veterinary professionals, requiring a multidimensional approach to management. By understanding the pathophysiology, clinical presentation, and treatment options for congestive heart failure, veterinarians can better care for canine patients with this condition, ultimately improving their outcomes and quality of life. Okay, let's chat about a case. A 7-year-old male golden retriever presents with a history of coughing, exercise intolerance, and recent onset of dyspnea. On physical examination, crackles are auscultated over the lung fields, and the dog appears tachypnic. Thoracic radiographs reveal cardiomegaly and pulmonary edema. So, what is the most likely diagnosis? Is it A, right-sided heart failure, B, left-sided heart failure, C, dilated cardiomyopathy, D, pulmonary fibrosis, or E, chronic bronchitis? What do you think is the correct answer and why? Let me know in the chat. Did you get it? The correct answer was B, left-sided heart failure. The clinical signs of coughing, dyspnea, and crackles on auscultation, along with radiographic evidence of pulmonary edema and cardiomegaly, are indicative of left-sided heart failure. Option A, right-sided heart failure, was incorrect. Right-sided heart failure typically presents with signs of venous congestion such as ascites and hepatomegaly, not pulmonary edema and crackles. Option C, dilated cardiomyopathy, was incorrect. While dilated cardiomyopathy can lead to left-sided heart failure, the question asks specifically for the clinical presentation, which aligns more directly with left-sided heart failure. Option D, pulmonary fibrosis, was incorrect. Pulmonary fibrosis would present with respiratory signs, but not typically with cardiomegaly on radiographs. And option E, chronic bronchitis, was incorrect. Chronic bronchitis presents with coughing, but usually does not cause pulmonary edema or cardiomegaly. Okay, that's it for tonight on this episode of Vet Candy's NAVLE Prep. I hope you enjoyed our talk and found it helpful for your studies. If you have any questions, please put them in the chat and we'll answer you. All the best and good luck with the exam.